Welcome to the Deep Dive, the place where we cut through the noise and deliver you the essential insights you need to truly master complex topics. Today, we're embarking on a journey into one of the most profound and intricate areas of human health, hemoglobin disorders. And just to kick us off, here's something pretty fascinating. Hemoglobin, the single protein, it isn't just hauling oxygen around, it's also like a silent witness to our evolution. It's been protecting populations from things like malaria for thousands of years.
Yeah.
Its story runs deep, but, well, its disorders are still huge medical challenges today.
Indeed. And when we talk about these disorders, we're mostly looking at two main groups. First, you have the haemoglobinopathies. These affect the actual amino acid sequence, the building blocks of the globin protein. And then there are the thalassaemias, which are different. They're about a reduced ability to actually make the globin chains, put them together, and, well, they're actually our most common single gene of Mendelian genetic diseases. And they're behind the vast majority of cases of hemolytic anemia, where red blood cells get destroyed too early that we see worldwide.
It's kind of staggering, isn't it? How one protein can cause such a huge spectrum of problems. You get everything from people who have no symptoms at all, carriers who might not even know they have a trait, like heterozygous sickle hemoglobin, all the way to conditions so severe they can cause death even before birth, like when all the alpha globin genes are missing entirely. It really shows you the delicate balance in our biology.
It absolutely does. And that's why for this deep dive, our goal is to give you the kind of detailed understanding that the top professionals have. Think of this as your master key to really unlocking hemoglobin disorders. We'll unpack the basic biology of hemoglobin itself, look at how doctors diagnose these conditions today, the sophisticated approaches, and dive into the very latest treatments, some of which are truly transforming lives.
All right, let's unpack this then. Before we jump into the disorders themselves, we really need to understand the star player here, hemoglobin. What exactly is this molecule, and what's its main job in our bodies?
Okay, so at its core, hemoglobin is the protein responsible for transporting oxygen. It's like a super efficient delivery service inside your red blood cells. Its basic structure is quite elegant, really. It's made of 4 separate protein chains. We call those globin chains. And tucked inside each of those 4 globin chains is a special structure called a heme group. It's a ring, a tetraperoyl ring, with an iron atom right at the center. And that heme group, specifically the iron, is where the magic happens. Oxygen grabs onto the iron as blood flows through the lungs. And then, crucially, it gets released into the tissues all over your body, where it's needed for, well, basically everything cells do.
So it's definitely not just a simple bucket carrying oxygen. It sounds incredibly structured, almost architectural. Can you walk us through that structure from the basic bits up to the whole working molecule?
Precisely. It's built in layers, you could say. We talk about 4 levels of structure. First, the primary structure. That's simply the specific sequence of amino acids, like beads on a string, that make up each globin chain. The alpha globins have 141 amino acids. The beta-like globins, that includes beta itself, but also gamma, delta, and epsilon, they're a bit longer, 146 amino acids. Then you have the secondary structure. Those amino acid streams don't stay straight, they fold up into regular patterns. In hemoglobin, it's mostly alpha helices, like little coiled springs connected by shorter, less structured bits. The tertiary structure is how each individual globin chain folds up into a specific 3D shape. It's often called the globin fold, and how it folds is critical. The amino acids with electrical charges tend to face outwards towards the watery environment inside the cell. The uncharged ones, the hydrophobic ones, they get tucked away on the inside. This folding creates a perfect little hydrophobic pocket, a safe place for that heme group to sit. And this pocket is vital because it protects the heme's iron atom. For oxygen to load and unload properly, that iron must stay in its reduced state, the ferrous form, which is Fe++10.
Okay, and that protection is key, right? Because if something goes wrong there...
Exactly. This is where structure directly links to disease. If a mutation changes one of the amino acids right near that heme-binding pocket, it can destabilize things, and the iron can get oxidized to the ferric form, Fe+++Go. When that happens, you get something called methemoglobin. And methemoglobin is basically useless for oxygen transport. It can bind oxygen, sure, but it holds onto it way too tightly. It doesn't release it to the tissues where it's needed. It's like a delivery truck that never drops off the package. And finally, the quaternary structure. It's the whole assembly. Individual alpha and non-alpha globin chains pair up to form dimers. And then 2 of these dimers come together reversibly to form the complete, functional, 4-subunit hemoglobin molecule, the tetramer. That's the workhorse.
That really clarifies how something seemingly small can be so complex and so vital. It's this intricate dance enabling the job. But its job isn't just moving oxygen and CO2 around, is it? You mentioned something else, and this is where it gets really interesting.
Absolutely. While oxygen and CO2 transport is its main gig, hemoglobin has another, quite important role that's often overlooked. It functions as a nitrate reductase. Basically, it can convert nitrite into nitric oxide, or NO, and nitric oxide is a really powerful signaling molecule. It's a vasodilator, it helps relax and widen blood vessels. So this hidden talent of hemoglobin plays a crucial part in regulating blood flow and keeping our vascular system healthy.
Wow, okay. So it's involved in blood pressure regulation too, in a way.
In a way, yes. And the efficiency of its main job, oxygen transport, is beautifully shown by the hemoglobin-oxygen dissociation curve. You've probably seen it. It has that characteristic S shape or sigmoidal shape. This reflects something called cooperative binding. A key point on this curve is the P50. That's the partial pressure of oxygen where hemoglobin is exactly 50% saturated. Normally, in a healthy person, the P50 is around 26 millimeters of mercury, or mmHg, but this isn't a fixed number.
Right. Other things can shift it.
Exactly. Several factors influence it. A big one is a molecule called 2-pound-3 bisphosphoglycerate, or 2-pound-3 BPG. It's made during glucose metabolism. 2-pound-3 BPG binds inside the hemoglobin molecule and actually lowers its affinity for oxygen, helping it release oxygen in the tissues. Then there's pH the Bohr effect. When tissues are active, they produce acid, lowering the pH. This shifts the curve to the right. A right shift means hemoglobin gives up its oxygen more easily, perfect for delivering oxygen where it's needed most. Conversely, a higher pH, alkalosis, shifts the curve left, meaning hemoglobin holds onto oxygen more tightly, reducing delivery. Temperature also plays a role. Higher temperature shifts the curve right, again helping oxygen release.
So it's constantly adapting to local conditions.
Precisely. You can think of hemoglobin existing in two main shapes or states. The R state, for relaxed, is when it's loaded with oxygen, high affinity. The T state, for tense, is when it's desaturated, lower affinity. The transition between T and R as oxygen binds is where cooperativity comes in. Binding the first oxygen molecule makes it easier for the second to bind, which makes it easier for the third, and so on. This makes oxygen loading in the lungs super efficient, and unloading in the tissues also very efficient.
And if that P50 value gets messed up, say by a mutation.
Then you see real clinical consequences. A low P50 means high oxygen affinity. Hemoglobin holds on too tight. Tissues might not get enough oxygen even if the blood seems fully saturated. The body might try to compensate by making more red blood cells, that's erythrocytosis. On the other hand, a high P50 means low oxygen affinity. Hemoglobin releases oxygen too easily. This can lead to cyanosis, that bluish tint, because there's more deoxygenated blood circulating, and potentially anemia because oxygen delivery isn't well regulated. Understanding these shifts is crucial for diagnosis.
Okay, that covers the protein itself. Now, where does the blueprint, the genetic information for making these globin chains actually live?
Good question. The genes are organized into two main clusters on different chromosomes. The beta-globin gene cluster is on chromosome 11, specifically on the short arm at position 11p15.4. This cluster contains the genes for embryonic epsilon globin, two fetal gamma globins, which are nearly identical, the main adult beta globin, and the minor adult delta globin. Then the alpha globin gene cluster is located on chromosome 16 at 16p13.3. This one has the gene for embryonic zeta globin and, importantly, two copies of the alpha globin gene. These two genes produce identical alpha globin proteins. Having two alpha genes is a key feature.
Two alpha genes, interesting. And how does production change as we develop? You mentioned embryonic, fetal, adult.
Right, there's a very precise developmental sequence. In the very early embryo, specialized hemoglobins are made, like Gower1, Gower2, Portland, FERD, and 2. Then, as the fetus develops, fetal hemoglobin, or HbF, takes over. HbF is made of two alpha chains and two gamma chains. Its production starts around 6 to 8 weeks of gestation, peaks mid-gestation, and then drops off sharply after birth, usually to less than 1% in adults. As HbF levels fall, adult hemoglobin A, or HbA, production ramps up. It's a reciprocal relationship. So a normal adult has mostly HbA, over 95%, plus that small amount of residual HbF, maybe 1%, and about 2-3% of HbA2, which is two alpha and two delta chains. Functionally, HbF and HbA2 don't do much in adults because they're in such low amounts, but measuring their levels is incredibly useful for diagnosing various disorders.
Like flags indicating something might be wrong with beta globin production, perhaps?
Exactly. And one more quick point, hemoglobin can be modified after it's made. The best known example is HbA1c. Glucose in the blood can attach to HbA non-enzymatically. Measuring HbA1c gives you an average blood sugar level over the past few months, vital for managing diabetes.
So we've got this fascinating developmental timeline for hemoglobin. What does this all mean for a growing human, and how exactly do our bodies manage this complex transition from one type of hemoglobin to another?
This whole process, the turning on and off of different globin genes during development, is called hemoglobin switching. It's tightly controlled and linked to where red blood cells are being made. First in the yolk sac, then the fetal liver, and finally settling in the bone marrow for adult life. These switches are essential to match oxygen delivery to the changing needs of the developing baby and then the child.
And how is it controlled? What tells the genes when to switch?
It's incredibly complex. It involves a whole orchestra of molecules, specialized proteins called transcription factors, chemical marks on the DNA called epigenetic modifications, things like methylation and powerful DNA regions called enhancers. For the beta globin genes, understanding this switch is a huge focus because reactivating fetal hemoglobin, HbF, is a major therapeutic goal for sickle cell and beta thalassaemia. There's a key regulatory region upstream called the beta globin locus control region, or LCR. Think of it as the master switchboard. The LCR interacts with the individual globin gene, promoters the on switches right next to the genes. There's competition between the genes for the LCR's attention. Specific transcription factors are responsible for silencing the embryonic and fetal genes at the right time. This silencing directs the LCR towards the adult beta gene.
And you mentioned factors that silence HbF. That sounds important for therapy.
Hugely important. Factors like BCL11A on chromosome 2 and ZBTB7A on chromosome 19 are crucial repressors of the gamma globin genes, the ones that make HbF. BCL11A actually binds directly to the HbF gene promoters and shuts them down in adults. What's really fascinating is that some people have natural mutations in the BCL11A binding sites. These mutations prevent BCL11A from binding, so their HbF genes don't get silenced. They have a benign condition called hereditary persistence of fetal hemoglobin, HPFH.
So studying them gave clues for treatment.
Exactly. It showed that if you could somehow interfere with BCL11A, you could potentially turn HbF back on in patients with sickle cell or beta thalassaemia. And that's precisely what new gene therapies are aiming to do, using things like CRISPR to edit those BCL11A binding sites or reduce BCL11A levels. It's a prime therapeutic target. Alpha globin switching is a bit simpler. It involves a regulatory region upstream and happens earlier, around 6 weeks gestation, switching from embryonic zeta-globin to adult alpha globin.
And what about natural variation? Why do some people, even with the same disease, have different HbF levels?
That's where quantitative trait loci, or QTLs, come in. These are genetic regions that influence measurable traits, like HbF levels. 3 major QTLs explain a lot of the variation we see. BCL11A itself, another gene called MYB on chromosome 6, and a region linked to the HBB cluster on chromosome 11. We talked about BCL11A silencing HbF. MYB also plays a role in inhibiting HbF, partly by affecting how red blood cells develop. And subtle variations within these QTL regions, like specific single nucleotide polymorphisms, SNPs, can lead to higher or lower baseline HbF levels. For instance, certain genetic backgrounds or haplotypes associated with the sickle cell gene, like the Senegal and Arab Indian haplotypes, tend to have naturally higher HbF levels. This is linked to specific variants near the gamma globin genes and often correlates with milder disease.
That was a truly deep dive into the biology. Now let's pivot. How do all these intricate details actually show up in patients? And crucially, how do doctors diagnose these complex conditions?
Okay, so moving to diagnosis. Generally, most of these disorders are inherited as autosomal recessive or codominant traits. This means a family history is often a big clue. If parents are carriers or if other family members have anemia or related symptoms, that points towards these conditions. Clinically, common signs that might make a doctor suspicious include pallor, unusual paleness or jaundice, that yellowish tinge to the skin or eyes from red cell breakdown. An enlarged spleen, splenomegaly, is also pretty common. And specifically for sickle cell, those sudden, severe vaso-occlusive pain episodes are a major red flag.
So what's in the diagnostic toolkit? What tests are run?
It usually starts with some basic but crucial lab tests. A complete blood count, CBC, is fundamental, looking at red cell size, MCV, hemoglobin content, MCH, MCHD, and especially the reticulocyte count. A persistently high reticulocyte count suggests hemolytic anemia, the body's trying hard to replace destroyed red cells. Then, a careful look at a peripheral blood film under the microscope is essential. A trained eye can spot characteristic cell shapes.
Like the sickle cells themselves.
Exactly. Or target cells, fragmented cells, cells with inclusions, they all provide visual clues. After that, hemoglobin fractionation is key. This is usually done by HPLC, high-performance liquid chromatography, or capillary electrophoresis. These techniques separate the different types of hemoglobin present, identifying abnormal ones like HbS or HbC, or measuring the levels of HbA2 and HbF. Often, this analysis, especially if you can test family members too, is enough to pinpoint the phenotype which hemoglobin variant is involved. But for a definitive diagnosis, particularly for genetic counseling or prenatal testing, you really need DNA sequencing of the globin genes. That identifies the exact mutation.
You mentioned sickle cell and beta thalassemia are both beta globin issues. Are there overlaps in how they present or are treated?
Yes, definitely. Since both involve the beta-globin gene and result in chronic hemolytic anemia, they share some common complications. Things like a higher risk of blood clots, venous thrombosis, painful leg ulcers, and pulmonary hypertension can occur in both. Both can potentially be cured by hematopoietic stem cell transplantation. And therapeutically, a major shared goal is inducing high levels of fetal hemoglobin, HbF. HbF helps prevent HbS polymerization in sickle cell, and it compensates for the lack of HbA in beta thalassemia. It's a common strategy.
Okay, let's zoom right in on sickle cell disease then. It's so prevalent globally, affecting millions. A single amino acid change with such profound consequences. It really is profound. And sickle cell disease isn't monolithic. It's a phenotype caused by various genotypes. The most common, usually most severe form is sickle cell anemia. That's when someone is homozygous for the HbS mutation. They inherited the mutated gene from both parents. The mutation itself is that single amino acid swap, glutamic acid replaced by valine at position 7 of the beta-globin chain. We denote it ADUS2. The next most common type is HbSC disease. This is a compound heterozygote, one HbS gene and one HbC gene. The HbC mutation is a different swap at the same position, glutamic acid to lysine. Generally, HbSC disease tends to have a later onset and be less severe than sickle cell anemia, HbSS. Then you have various HbS beta thalassemias, where someone inherits an HbS gene and a beta thalassemia gene. The severity depends heavily on the type of thalassemia mutation, beta 0 or beta plus. There are also rarer combinations like HbS-ORB or HbSE, but HbSS, HbSC, and HbS beta fall are the main ones. And the origin story is fascinating, tied to malaria resistance, right?
Exactly. The HbS gene arose in Africa thousands of years ago. Its high frequency today is a classic example of natural selection. People who are heterozygous carriers with just one HbS gene, sickle cell trait, are significantly protected against severe malaria. This survival advantage allowed the gene to spread widely in malaria-endemic regions. The gene is associated with 5 common genetic backgrounds, or haplotypes Benin, Bantu, Senegal, Cameroon, Arab Indian. These haplotypes have some loose correlation with disease severity, mainly because they're linked to slightly different baseline HbF levels. As we said, higher HbF is generally better.
And the global impact is huge.
It's staggering. In parts of Africa, India, the Middle East, nearly half the population might carry the trait. Nigeria sees about 150,000 babies born with sickle cell anemia each year, a third of the world's total. Tragically, without access to care, many die before age 5. But due to population movements, the gene is now global. In contrast, in places like the U.S., with around 100,000 patients, modern care means childhood death is rare, and median survival is now into the 50s or 60s. A stark difference.
Let's get to the core mechanism, that deoxygenation polymerization cascade. It sounds complicated, but it's key, isn't it?
It's absolutely the heart of the matter. The fundamental issue is that deoxy-HbS sickle hemoglobin without oxygen bound is unstable. When it gives up its oxygen, it polymerizes. It forms long, stiff, rod-like fibers inside the red blood cell. This starts with specific contacts between that abnormal beta-7 valine on one HbS molecule and other amino acids on adjacent molecules. These contacts allow the molecules to stack up into these damaging polymers or fascicles. There's a crucial, though very short, delay time between deoxygenation and enough polymer forming to actually damage the cell. The polymer itself physically distorts the red cell, but it also triggers a cascade of other problems.
Your kinds of problems.
Well, the polymers can poke through the cell membrane, causing bits to break off, vesiculation. Key ion channels on the cell surface, like the Gardose channel and others, become overactive. This leads to the cell losing potassium and water it dehydrates. Dehydration concentrates the HbS inside, making it more likely to polymerize. A vicious cycle. The cell membrane itself changes, flipping lipids like phosphatidylserine to the outside, making the cell stickier, and the cell contents get oxidized. Eventually, this damage leads to irreversibly sickled cells, ISCs. These cells are permanently deformed, stuck in that sickle shape. Even if the HBS inside isn't currently polymerized, they've suffered too much membrane damage.
And these damaged, sticky, deformed cells cause the main problems.
Precisely. They lead to the three key features of the disease. First, vasoocclusion. The sickled cells are rigid and sticky. They interact abnormally with the blood vessel lining, endothelium, and other blood cells. They literally block blood flow, especially in small vessels. This causes the intense pain crises and contributes to chronic organ damage. Second, hemolysis. Sickle cells just don't last long. Normal red cells live about 120 days. Sickle cells often survive less than 20. They break down both inside blood vessels, intravascular hemolysis, and get removed by the spleen and liver, extravascular. Intravascular hemolysis releases free hemoglobin and heme into the plasma, which depletes protected molecules like haptoglobin and hemopexin. And this leads to the third feature, inflammation. The free heme and other debris released during hemolysis are highly inflammatory. They scavenge nitric oxide, NO, causing blood vessels to constrict. They activate platelets and endothelial cells, promoting more stickiness and clotting. They impair antioxidant defenses. It creates a chronic inflammatory state that damages organs over time. So it's sickling damage, obstruction, inflammation, more damage. A really nasty cycle.
Okay, so when diagnosing, you're looking for that ethnic predisposition. But what are the key symptoms and lab findings?
Right. While it can occur in anyone, it's most common in those with African, Middle Eastern, Mediterranean, or Indian ancestry. The main symptom, especially early on, is pain. In infants, it might be hand-foot syndrome, painful swelling. In older kids and adults, it's those acute, painful episodes. Remember, in HBSC or HBS beta plus thalassaemia, symptoms might be milder or start later. Lab-wise, for sickle cell anemia, HBSS, you typically see hemoglobin between 7 and 10 GDL. Red cell size, MCV, might be normal or slightly high, and you'll always see high reticulocytes reflecting that high cell turnover.
And the HPLC is definitive.
It's crucial. For HBSS, HPLC shows predominantly HBS, usually 75%, some HBF, 25%, and normal or slightly high HbA2, no HbA. For HBSC, you see roughly equal amounts of HBS and HBC, maybe 50-50. For sickle cell trait, the carrier state, you see more HbA than HBS, maybe 60% HbA, 40% HBS.
And the blood film. What do you actually see under the microscope?
The morphology is key. In HBSS, you look for those classic, dense, elongated, crescent-shaped, irreversibly sickled cells, ISCs. You also often see target cells and some nucleated red blood cells, immature cells escaping the marrow. In HBSC, you see lots of target cells too, but also characteristic HBC crystal cells that look almost rectangular, plus folded cells, maybe some microspherocytes. It looks quite different from HBSS. While these findings usually clinch the diagnosis, DNA testing is still needed for precise genetic counseling.
The pathology of sickle cell disease is truly widespread, leading to a host of complications. It really drives home the systemic impact.
Absolutely. The complications are incredibly diverse. You can broadly group them into those mainly caused by vasoocclusion and those driven more by the chronic hemolysis. Interestingly, treatments that boost HbF, like hydroxyurea, seem particularly good at preventing the vasoocclusive complications. And thankfully, with modern care, the really severe manifestations we used to see are becoming less common.
Let's talk through some major ones. Acute painful episodes sound like the most common issue. By far. These are episodes of severe, unprovoked pain, often in the limbs or back. They're the main reason for emergency visits and hospitalizations. Frequency varies massively between patients. Some have few, others are in pain almost constantly. They can last days or weeks. Diagnosis is clinical, there's no specific test. You might see a slight dip in hemoglobin, a modest rise in white cells, but that's not specific. It's complicated because this acute pain can overlap with chronic pain from things like bone damage, osteonecrosis, or leg ulcers. Many patients live with baseline chronic pain.
It's centered on prompt and adequate opioid pain relief. Many patients are opioid tolerant due to chronic pain, so they need appropriate doses. Intravenous opioids, often via PCA, patient-controlled analgesia, or fixed frequent doses, are standard. Rescue doses for breakthrough pain are important. Adjunctive care includes things like incentive spirometry to prevent lung issues, careful hydration, avoiding overhydration, blood clot prevention, thromboembolism prophylaxis, and managing opioid side effects like itching and constipation. Supplemental oxygen isn't usually needed unless they're truly hypoxic, and strong NSAIDs like ketorolac don't add much benefit over IV opioids and can have risks, especially kidney risks if there's any hypoxia. Sadly, there's a small risk of sudden death during these episodes, possibly from arrhythmias or pulmonary embolism. Close monitoring is key.
What about acute chest syndrome? That sounds serious.
It's the second most common acute event, affecting over half of patients at some point, often recurrently. It's like a severe pneumonia. It can range from mild, especially in kids, to life-threatening with respiratory failure. Diagnosis needs a new infiltrate on chest x-ray plus symptoms like chest pain, cough, fever, or hypoxia. The causes are varied clots forming in the lungs, in situ thrombosis, clots traveling from elsewhere, emboli often from bone marrow, infection, even just poor breathing after surgery.
And treatment for that.
If they're hypoxic or feverish, they often need ICU care. Broad-spectrum antibiotics are usually given due to infection risk. Supplemental oxygen if saturation drops below 95%. Careful fluid management is crucial to avoid overload. And careful opioid use to avoid suppressing breathing. Transfusion is often needed, especially if they're very hypoxic or have widespread lung involvement. Simple transfusion, or for severe cases, red cell exchange transfusion is preferred. Certain signs suggest a worse prognosis, like falling platelet counts, very high white cell counts, or rapidly worsening anemia. And many adults develop chronic lung disease over time, likely from repeated ACS episodes. Asthma is also very common.
Osteonecrosis sounds incredibly painful, too.
It is a vascular necrosis or bone death due to lack of blood supply. It affects about 50% of HBSS patients, also common in HBSC. Most often hits the hips, often both sides, sometimes shoulders, causes chronic debilitating pain, loss of function. MRI detects it early. Treatment involves physical therapy, pain meds, NSAIDs, sometimes opioids, and often, eventually, joint replacement surgery, especially for hips.
And leg ulcers.
Another tough complication. More common in HBSS, HBS beta than HBSC, HBS beta plus META. Incidence varies geographically higher in tropical areas. They can be small or huge, incredibly painful, and very hard to heal. Treatment involves specialized dressings, compression like Una boots, but it's often a long battle.
Okay, there's a whole list of others, too. Priapism, stroke.
Right. Priapism, prolonged painful erection, affects about 30% of males, can lead to impotence if not treated fast. Stroke and silent brain infarcts affect 10–15%. That's why transcranial Doppler, TCD screening, is vital in children, ages 2–16, to identify high-risk kids who need preventive transfusions or hydroxyurea. Gallstones are common, around 40%, due to chronic hemolysis. Simple transfusion before surgery is recommended. Liver disease can range from bile flow problems, cholestasis to cirrhosis, sometimes needing exchange transfusion or even transplant. Kidney disease, nephropathy, affects about 30% of adults over 30, progressing towards kidney failure. Screening, ACE inhibitors, sometimes dialysis or transplants are needed. Lung disease and pulmonary hypertension need monitoring with echocardiograms and expert care. Eye problems, retinopathy, especially in HBSC, need annual screening and laser treatment if necessary. Acute worsening of anemia can happen due to parvovirus B19 infection, folate deficiency, or splenic sequestration, where the spleen suddenly traps red cells, often needing transfusion. Multi-organ failure is a devastating complication, often linked to severe ACS, requiring ICU support and exchange transfusion. And pregnancy is high risk, requiring specialized care, partner screening, and sometimes transfusion.
What about sickle cell trait, the carrier state? Is it always completely benign?
Mostly yes. Carriers vastly outnumber patients, maybe 25–1, and usually have a normal lifespan. But it's not entirely without risk. There are small but definite increased risks of blood in the urine, hematuria, a specific kidney problem, papillary necrosis, inability to concentrate urine, hyposthenuria, chronic kidney disease, and blood clots. VTE about 2–4 times increased risk. There might be a slightly increased stroke risk, too. Splenic infarction can happen at high altitude, and a key one is exertional rhabdomyolysis.
Rhabdomyolysis, muscle breakdown.
Yes, particularly during intense exercise, especially in heat and dehydration. There's a very small but real risk of sudden death in athletes with sickle cell trait under these conditions. So, counseling is crucial for carriers. They need to know about these small risks, the implications for having children, and definitely about the exercise risk and the importance of hydration. Many people don't even know they have the trait.
The treatment landscape has really changed, hasn't it? Moving towards prevention and even cure.
It's been a remarkable transformation. Referral to a specialized sickle cell center with a multidisciplinary team is ideal. Pharmacologically, hydroxyurea is the absolute cornerstone, standard of care for all HBSS and HBS beta patients, regardless of symptoms, starting ideally in infancy. Its main job is boosting fetal hemoglobin, HbF. This HbF interferes with HbS polymerization, protecting the red cells. The benefits are huge. Reduces pain crises in ACS by about half, raises baseline hemoglobin by about 1 GDL, and studies show it reduces mortality significantly over the long term. Children respond particularly well, often reaching very high HbF levels and near normal hemoglobin with early treatment. Dosing starts around 20 millibilgrams and is carefully adjusted based on blood counts.
And the newer drugs, voxelotor, crizanlizumab.
Right. Voxelotor works differently. It increases hemoglobin's affinity for oxygen, lowers P50, making it less likely to deoxygenate and polymerize. It raises hemoglobin levels and reduces signs of hemolysis. Whether this translates to fewer vaso-occlusive events long-term is still being fully clarified, but later analyses suggest it might, especially in those with the best hemoglobin response. Key questions remain about long-term organ protection and potential downsides of very high oxygen affinity. Crizanlizumab targets P-selectin, a molecule involved in the cell stickiness that causes vasoocclusion. It's a monthly IV infusion. It reduced painful episodes by about 45% in trials, similar to hydroxyurea's effect, but it doesn't affect hemolysis. Then there's L-glutamine, an oral powder thought to reduce oxidative stress. It showed about a 25% reduction in pain episodes and fewer hospitalizations in trials.
How do these fit together?
There's no single guideline yet, but generally their effects seem additive. You'd likely start with hydroxyurea. If the response isn't enough, common in adults, you might add voxelotor. If vaso-occlusive events still persist despite both, crizanlizumab could be added. L-glutamine might also be considered. Adherence to these complex regimens can be a challenge, though.
What about transfusions? When are they used?
They're critical but need careful use. Major indications are severe anemia causing symptoms, treating or preventing stroke, especially in kids, preparing for major surgery, aiming for HB around 10 GDL, and severe acute chest syndrome, sometimes used in high-risk pregnancies. Importantly, they're generally not used for uncomplicated pain crises or just to top up stable chronic anemia. For acute stroke, severe ACS, multi-organ failure, or chronic transfusion therapy, automated red cell exchange is often preferred. It's efficient at replacing sickle cells while minimizing iron buildup. Key guidelines now stress extensive red cell antigen typing before the first transfusion, if possible, and matching for Rh, C, E, C, and K antigens beyond the basic ABO-HC match. This is crucial to reduce alloimmunization, the patient developing antibodies to donor blood.
Transfusions have risks too, though.
Absolutely. Besides alloimmunization, which is a growing problem, there's risk of iron overload requiring chelation therapy, hyperviscosity if the hematocrit gets too high, delayed hemolytic reactions, and a rare but severe complication called hyperhemolysis, where transfusion triggers massive destruction of both donor and patient cells.
And stem cell transplant, the curative option.
Yes, hematopoietic stem cell transplantation offers a cure. Using cells from an HLA-identical sibling gives excellent results, over 95% event-free survival. It should be considered if a matched sibling donor exists. The big limitation is that only about 15% of patients have such a donor, but results are improving for transplants using partially matched family members, haploidentical donors, which greatly expands the potential pool.
Prevention sounds key too, especially starting early.
Definitely. Newborn screening, cord blood testing, is done widely now, allowing for immediate preventive care. In childhood, this includes the TCD screening for stroke risk, prophylactic penicillin until age 5 to prevent sepsis, and crucial pneumococcal vaccines. Folic acid is often given, though maybe not essential with good nutrition. For family planning, screening potential parents, counseling about risks, and offering antenatal diagnosis, like chorionic villus sampling early in pregnancy, are vital.
This is truly where the cutting edge shines: gene therapy, offering a cure without needing a donor.
That's the incredible promise. Gene therapy aims to be curative without needing a matched donor or lifelong immunosuppression. The basic idea is to take the patient's own hematopoietic stem cells, CD34 plus cells, modify them in the lab to either produce healthy hemoglobin or effectively block sickling, and then give them back to the patient after conditioning therapy, chemo, to make space for them. Several approaches are in trials. Some use lentiviruses to deliver a corrected or modified beta-globin gene, an anti-sickling version. Others use gene editing tools like CRISPR-Cas or zinc fingers to disrupt the BCL of NA gene or its regulatory elements. The goal here is to reactivate the patient's own fetal hemoglobin HbF production. Early results are stunning. Patients are achieving high levels of HbF or the therapeutic anti-sickling globin, often near 50%. Hemolysis decreases, total hemoglobin increases, often 11 GDL, and crucially, vaso-occlusive crises have resolved in many trial participants. It's still early days. We need long-term safety and efficacy data, but the potential to offer a widespread cure is truly revolutionary.
Okay, that brings us to the thalassemias. Different mechanism, but also fundamentally genetic, right? You describe them as an imbalance of globin chains.
Exactly. That imbalance is the defining feature. Unlike sickle cell, where the structure of hemoglobin is the primary problem, in thalassemia, the problem is the quantity. There's reduced production of either alpha or beta globin chains. This leads to a relative excess of the other, partner chain. These leftover unpaired chains are unstable and toxic. They precipitate inside the developing red blood cells, erythroblasts, in the bone marrow, causing damage and death of these precursors. This is called ineffective erythropoiesis, and it's a major cause of the anemia in severe thalassemia.
Cases like sickle cell, they're common in certain regions due to malaria protection.
Yes, the carrier state, heterozygote, confers some protection against malaria, so the genes reached high frequencies in tropical and subtropical areas, Mediterranean, Middle East, Africa, Asia. Worldwide, maybe 1–5% of people carry a thalassemia mutation. In some places, it's much higher. There are hundreds of different mutations, known, 500, affecting either alpha or beta chains, and they can interact with each other and with hemoglobin variants like HBS or HBE. This creates a huge diversity of clinical syndromes. Genetic counseling and prenatal diagnosis are really important. And remember, variants like HBE and HB constant spring, they technically aren't thalassemia mutations, but they behave like them because they lead to reduced production or unstable globin chains, causing that same imbalance.
Let's focus on beta thalassemia first, historically called Mediterranean anemia.
Right, or Cooley's anemia. But effective screening in the Mediterranean has drastically reduced new cases there. Now, most new patients are of Asian, Middle Eastern, or Indian descent. Globally, maybe 40,000 affected births per year, about 1,000 severe cases in the U.S.
How's it classified? Beta 0, beta plus?
Those terms describe the mutation's effect. Beta 0 mutations completely prevent any beta globin production from that gene. Beta plus, POLA plus mutations allow some beta globin production, but significantly reduced amounts. But clinically, we now often classify based on transfusion needs. Transfusion-dependent thalassemia, TDT, versus non-transfusion-dependent thalassemia, NTDT. TDT patients typically have 2 beta mutations, or one 0 and one severe weight plus edge, and require regular lifelong transfusions from infancy to survive and prevent severe complications. NTDT includes milder forms, maybe 2 moderate plus mutations, or beta thalassemia combined with beta thalassemia, where transfusions are infrequent or not needed at all, though they still have complications.
And the underlying problem is always that lack of beta globin.
Yes. Most mutations are single DNA-based changes, but deletions happen too. They can affect gene promoters, RNA splicing, RNA processing, translation start sites, or create premature stop codons. Lots of ways to mess up beta globin production. The result is always that deficit of beta globin, leading to an excess of alpha globin chains. These unpaired alpha chains precipitate in the erythroblasts, causing massive cell death in the marrow, ineffective erythropoiesis. That's the main driver of the anemia. Any red cells that do make it out are damaged, less deformable, and get destroyed quickly in the circulation hemolysis.
What happens if it's poorly treated?
Historically, the consequences were devastating. Severe anemia leads to massive bone marrow expansion, causing facial deformities, fragile bones, huge liver and spleen enlargement, hepatosplenomegaly, and severe growth failure. Plus, crippling iron overload from repeated transfusions and increased gut absorption due to the anemia itself damages the heart, liver, and endocrine glands, leading to early death. Thankfully, modern treatment with regular transfusions plus effective iron chelation therapy prevents most of these horrific outcomes. Transplant offers a cure for some.
How is it diagnosed? Let's start with the carrier state, beta thalassemia trait.
Okay, heterozygous beta thalassemia trait or minor usually causes only mild or no anemia. But the red cells are distinctly microcytic, small, low MCV, and hypochromic, pale, low MCH-MCHC. Reticulocytes are usually normal or only slightly up. The key diagnostic finding after ruling out iron deficiency, which also causes microcytosis, is an elevated HbA2 level on HPLC or electrophoresis. HbF might also be slightly elevated. Identifying the specific mutation via DNA analysis is crucial for accurate genetic counseling.
And the severe forms.
These present as severe hemolytic anemias. The blood film is dramatic, severe hypochromia, microcytosis, marked variation in cell size, anisocytosis, and shape, poikilocytosis, target cells, fragmented cells, and often lots of nucleated red blood cells.
Complications seem mainly driven by the anemia and the iron overload.
Primarily, yes. Chronic hemolysis, chronic transfusions, and iron loading, which is also significant in NTDT due to increased absorption, are the main culprits. Most severe complications arise from inadequate transfusion or, more often today, inadequate iron chelation. Even with optimal chelation, some iron toxicity often develops over a lifetime. Iron stores are monitored with serum ferritin levels, but more accurately by MRI scans measuring iron in the liver and heart. using T2 sequences.
Can you run through the main complications?
Sure, growth retardation and delayed puberty fertility issues are common, especially if treatment wasn't optimal early on. Splenomegaly occurs as the spleen works overtime removing damaged cells and may try to make blood cells itself. If it gets too large and destroys too many cells, hypersplenism, increasing transfusion needs, splenectomy might be needed, but that increases infection risk. Heart problems are a major cause of death, heart failure from chronic anemia, and iron toxicity, arrhythmias, pulmonary hypertension. Cardiac MRI T2 is vital for monitoring iron. Leg ulcers can occur, especially in NTDT. Liver disease, fibrosis, cirrhosis is driven by iron overload and viral hepatitis from past transfusions. Monitored by liver MRI. Lung disease, pulmonary hypertension are common due to various factors, including chronic hemolysis and clots. Thromboembolism, blood clots, risk is increased, multifactorial. Endocrinopathies are very common due to iron-damaging glands. Diabetes, hypothyroidism, hypoparathyroidism, adrenal insufficiency, hypogonadism. The pituitary is very sensitive. Bone disease includes osteoporosis from marrow expansion, iron, hormone deficiencies, and sometimes painful masses of extramedullary hematopoiesis, blood cell production outside the marrow, and increased risk of certain infections partly due to iron overload or splenectomy.
So management is intense. Lifelong transfusions and chelation.
For TDT, yes. Regular transfusions every 2 to 4 weeks aiming for pre-transfusion HB9 10.5 GDL combined with continuous iron chelation therapy are the standard. This regimen, started early and maintained lifelong, prevents the worst complications and allows survival into middle age and beyond. We now have effective oral chelators, deferostyrox, defuraprone, alongside the older injectable deferoxamine, but it's a huge burden for patients.
Is transplant an option here too?
Yes, hematopoietic stem cell transplant from a matched sibling donor offers a cure in over 80% of cases and is often recommended if a donor is available, especially for younger, well-chelated patients. Quality of life is generally better post-transplant. Again, only about a third have a matched sibling. Results with alternative donors, haploidentical, unrelated, are improving but still carry higher risks.
Are there drugs that help the underlying ineffective erythropoiesis?
Yes. One relatively new drug is luspatercept. It's a fusion protein that targets specific growth factors, TGFO superfamily ligands, involved in red cell maturation. By modulating signaling, reducing SMAD23, it helps late-stage erythroblasts mature more effectively, reducing ineffective erythropoiesis. It's given by injection every 3 weeks and can reduce transfusion needs by about a third in many TDT patients.
And gene therapy for beta thal.
Also making huge strides, similar to sickle cell. Lentiviral vectors are used to insert a functional beta-globin gene into the patient's own stem cells. One such therapy is already approved in Europe for certain TDT patients lacking a donor. Clinical trials show many patients become transfusion independent with stable hemoglobin levels, although the underlying ineffective erythropoiesis might not be fully corrected. And again, the CRISPR-Cas editing approach targeting BCL11A to boost HbF is also showing great promise in beta thalassaemia trials, potentially normalizing hemoglobin without transfusions.
Okay, let's switch to alpha thalassemia.
Yeah.
The obverse, you said, lack of alpha chains this time.
Exactly. Here the problem is a shortage of alpha-globin chains, leading to an excess of non-alpha chains, beta in adults, gamma in fetuses.
Yeah.
Clinically significant alpha thalassemia is generally less common than severe beta thal. It's most prevalent in Asian populations, often caused by gene deletions.
But carriers are common.
Very common in tropical, subtropical regions, Africa, Asia, etc., up to 80% in some areas. About 30% of African Americans carry the common NB3.7 deletion, missing one alpha gene on one chromosome. Hemoglobin H disease, the main clinical form, is most common in southern China, Southeast Asia. HB Bart's hydrops fetalis, the most severe form, also occurs primarily there.
How is alpha thal classified? It depends on how many alpha genes are working.
Precisely. Normal individuals have 4 alpha genes, 2 on each chromosome 16. Missing 1 or 2 genes results in alpha thalassemia trait, usually clinically silent or very mild microcytic anemia. Missing 3 alpha genes causes hemoglobin H, HbH disease. This is a moderate to severe hemolytic anemia. Missing all 4 alpha genes results in hemoglobin Bart's hydrops fetalis syndrome. This is incompatible with life without intervention. There's complexity due to different types of deletions and rarer non-deletion mutations.
And the pathophysiology is the excess non-alpha chains.
Yes. Reduced alpha globin means unpaired non-alpha chains form unstable tetramers. In the fetus, excess gamma chains form HB Barts. This has extremely high oxygen affinity. It basically doesn't release oxygen to tissues. Catastrophic for the fetus. In adults or children after the gamma to beta switch, excess beta chains form HbH filter 4. This also has very high oxygen affinity and is unstable. The unstable HBH precipitates in red cells, causing membrane damage, leading to hemolysis, mainly extravascular in the spleen, and some ineffective erythropoiesis.
How is alpha trait diagnosed since HbA2 isn't high?
Good point. Presumptive diagnosis of alpha trait is made by finding microcytosis and hypochromia with a normal or near normal hemoglobin and normal HbA2 levels after ruling out iron deficiency. Definitive diagnosis and determining the number of missing genes requires DNA analysis, which is essential for genetic counseling.
And HbH disease.
Diagnosis involves the typical findings of hemolytic anemia, low HB, high reticulocytes, abnormal red cell shapes, plus detection of HbH itself. At birth, babies with HbH disease will have 20–30% HB BARTs. Later in life, they have variable amounts of HbH, traced to 40%, detectable by HPL electrophoresis. You can also see HbH inclusions in red cells using special stains, brilliant crescent blue. For HB BARTs hydrops fetalis, the fetus has almost entirely HB BARTs, maybe some embryonic HB portlet.
What are the complications of HbH disease?
It's quite variable depending on the exact genotype. Non-deletion forms, like HB constant spring combined with deletions, tend to be more severe. Patients typically have moderate anemia, HB around 811 GDL. They can develop splenomegaly, jaundice, thalassemic bone changes, and growth issues. Iron loading can occur over time, but is usually less severe than in beta-thal TDT. Pregnancy is high risk. For HB BARTs hydrops fetalis, it's usually fatal in utero or shortly after birth due to severe anemia and heart failure, hydrops. Pregnancies are high risk for the mother too, preeclampsia, hemorrhage. Intrauterine transfusions can allow survival, but survivors often have significant long-term problems, growth, neurodevelopmental. Prevention is really key here.
So management focuses on prevention for the severe forms.
Absolutely. For couples from endemic areas planning families, DNA testing is crucial. For alpha trait, the main advice is to avoid unnecessary iron supplements if they aren't iron deficient. For HbH disease, regular transfusions usually aren't needed, but might be required during infections, pregnancy, or other stresses. Iron stores should be monitored periodically, but chelation isn't typically required. Splenectomy might be considered for severe hypersplenism. For HB BARTs hydrops, prevention via screening and prenatal diagnosis is by far the best approach, given the severity of the condition and the challenges for survivors, even with intensive therapy like intrauterine transfusions.
While sickle cell and thalassemias are the big ones, you mentioned over 1,000 other mutations. Are there others we should know about?
Yes, the diversity is incredible. Most, as we said, are silent. But a few common variants are important clinically, mainly due to interactions or specific effects. HBC is common in people of African descent. Carriers, heterozygotes, are fine. Homozygotes, HBCC, have only very mild anemia and microcytosis. Its main importance is combining with HBS to cause HBSC disease. HBE is very common in Southeast Asia. Again, heterozygotes are fine. Homozygotes HBE have mild anemia and microcytosis. Its significance comes from interacting with beta thalassemia to cause HBE beta thalassemia, which can be severe. Definitive diagnosis for any rare variant really needs DNA analysis.
Are there unique clues that point towards some of these rarer variants?
Sometimes, yes. One classic scenario is finding unexpectedly low oxygen saturation on a pulse oximeter, SpO2, when the actual arterial oxygen saturation measured from blood is normal. This discrepancy strongly suggests a rare, high oxygen affinity hemoglobin variant. Recognizing this can save patients from a lot of unnecessary heart and lung investigations looking for a cause of hypoxia they don't really have. The hemoglobin is just holding oxygen too tightly for the pulse oximeter to read accurately.
What about M hemoglobins? You mentioned methemoglobin earlier.
Right. M hemoglobins are specific inherited variants where the mutation makes the heme iron prone to oxidizing spontaneously to the ferric F+++ state. The main clinical sign is usually asymptomatic cyanosis, a slate gray or brownish skin color. There are 9 known variants. They can be distinguished from acquired methemoglobinemia because adding cyanide turns regular methemoglobin red, but M hemoglobins are unaffected. No treatment is needed for inherited M hemoglobins.
And unstable hemoglobins.
These are mutations causing the hemoglobin tetramer itself to be unstable, so it precipitates inside the red cell, forming Heinz bodies visible with special stains. They are rare, often new mutations affecting the protein's folding. They cause a chronic non-spherocytic hemolytic anemia, usually mild, rarely needing transfusion. Examples include HB colon, HB Hascherin, HB Zurich. Diagnosis involves stress tests, like heating the blood, that make the unstable hemoglobin precipitate out. Some are picked up by HPLC.
Lastly, variants with altered oxygen affinity. high and low.
Yes, rare mutations affecting how hemoglobin binds oxygen. High-affinity variants are actually more common than low-affinity ones, about 2.1. High oxygen affinity variants cause isolated erythrocytosis, high red cell count, without other signs like splenomegaly, often familial. The left-shifted curve and low P50 mean less oxygen release, stimulating erythropoiesis. Generally benign, phlebotomy usually isn't needed. Diagnosing them avoids mistaken diagnoses like polycythemia vera. Low oxygen affinity variants present with mild anemia or cyanosis, high P50, usually picked up by HPLC treatment, often unnecessary.
Finally, it's crucial to remember, not all hemoglobin issues are genetic, right? Some are acquired.
Absolutely critical distinction. Carboxyhemoglobin, COHB, forms when carbon monoxide binds hemoglobin. COB binds incredibly tightly, much stronger than oxygen, blocking oxygen transport and shifting the curve left. It needs to be measured by co-oximetry on a blood gas sample. Pulse oximeters are useless here. CO poisoning causes headache, confusion, etc. Treatment is high-flow oxygen, sometimes hyperbaric oxygen. Then there's acquired methemoglobinemia. This is much more common than inherited hemoglobins. It happens when drugs or chemicals oxidize the heme iron to Fe+++I. It can also be caused by a deficiency in the enzyme CYB5R3, which normally reduces methemoglobin back to functional hemoglobin. Acquired methemoglobinemia causes cyanosis and symptoms of poor oxygen transport due to the non-functional methyl and the left-shifted curve. The CYB5R3 deficiency can be mild, type 1 affecting only red cells, or severe, type 2 affecting all cells, often fatal. Treatment for significant acquired methemoglobinemia, levels 20-30% are symptomatic, is intravenous methylene blue. It helps reduce the MET-FB. Important note, methylene blue doesn't work well and can be dangerous in people with G6PD deficiency. Ascorbic acid is an alternative for them. Common causes include drugs like dapsone, nitrates, and topical anesthetics like benzocaine, used in sprays for procedures.
What an incredible journey today. We've gone from the tiny details of hemoglobin structure and function through the complex genetics and developmental switches, all the way to the diverse clinical pictures of sickle cell, thalassemias, and other variants, plus the diagnostic tools and truly revolutionary treatments.
We really aim to provide that deep, comprehensive grasp, moving beyond just the surface facts to the kind of understanding elite professionals rely on. Hopefully, you now have a much clearer picture of not just what these conditions are, but why they happen and how medicine is tackling them.
And as we wrap up, here's something to think about. Hemoglobin adapted over millennia to protect against malaria. What other silent genetic protections might be lurking in our biology, waiting to be discovered? And how could uncovering them revolutionize medicine even further, just as understanding hemoglobin continues to do?
It really makes you reflect on that constant interplay between our genes, our environment, and the amazing innovations in human health. The hemoglobin story is a powerful example, and it's definitely still being written.